Well, I appreciate this opportunity to come be a part of this debate to demonstrate how wrong David is and how right I am. So in spite of, I guess one of the things that's always kind of I've marveled at is David Terrace is clearly a very talented individual who spent a good bit of time on something, and I just wish he would have devoted all of that intelligence and drive to something other than this. Maybe before we get into the presentation, maybe a little to a quick denial. By no means do I want to ever imply that what I'm advocating is a paternalistic approach. I think you'll hear that as we go forward. And choices certainly are important for all of us to offer our patients. We drill that into our fellows and residents' heads throughout their residency. It's our obligation as physicians to explain the alternatives of treatment, including in some cases not even offering any treatment for patients. And then it's ultimately the patient's responsibility to make a decision how he or she wants to proceed. But just as choices are important, it's, I think, important for us to recognize there are consequences of those choices, and we'll talk a little about that as we move forward. Just in the way of disclosures, I've served on the Scientific Advisory Board for the V Foundation for a number of years, and this is my assignment. So we're number one. That's a chant you will hear in high schools, colleges, universities, professional teams throughout the year. We're number one. You'll see that always on television, fans chanting and pointing up and raising a single finger. But as we clearly know, these ranking systems are not related to just sports. In the month of July in the United States, I suspect that these spaces are increasingly utilized by CEOs of medical centers who are anxiously awaiting the news that comes from the U.S. News and World Report, the rankings. And in fact, yesterday, for those of you who are part of the tremendous opening ceremonies, how many times did you hear about reference to the U.S. News and World Report rankings? So in the United States, these rankings are now being used as determinants of students where they want to attend medical school, medical students where they want to do their residencies, graduating residents and fellows where they want to be faculty members, and certainly, last but not least, patients are making their decisions about where they want to have their care, as are insurance companies. So rankings clearly are an important matter. So United States healthcare, yay, we're number one. That's great. That's from a report of the World Health Organization, about 10 years ago. But we're number one in costs. And last year, a staggering $2.7 trillion in the United States spent on health care. And so we're number one. Great. Well, that same World Health Organization report also reports that out of 191 countries ranked, the United States spends the greatest amount of money on health care, and in quality of the health care delivered for that, we're ranked 37. So we have clearly a disproportion of the resources we're investing and the product we're delivering to those who we serve. And so this is an unsustainable model in the United States at this point in time. We neither have the resources to continue, it's too expensive, it's relatively inaccessible, and there's some documentation that the quality of the product is not as what we would like it to be. So for the last now 10 years, the first report, David, was maybe 12 years ago, of these types of novel surgical procedures, remote access to the removal of thyroid masses, and then in 2012 comes the heels of another group recommending removing benign neck masses from either axillary or breast type approaches, remote accesses. And so as I listened to these and read these reports over these last 10 years, I guess it was these two reports that stimulated me to get into the trouble that I'm in this morning, and that is to express my views on that in an editorial to JAMA Otolaryngology Head and Neck Surgery a couple of years ago. And I intentionally made this to be a little provocative, so the title is why are more costly and more dangerous surgical procedures being developed. I haven't done an extensive review of the literature, but I would doubt that there are too many cases of standard removal of thyroid masses that have injuries to the brachial plexus reported as a complication. I would doubt that there will, and David, I applaud you for your alternative approach to this now. Now we're doing facelift surgery, unilateral, I presume, to get access to thyroid nodules. So we're putting the brachial plexus and we're putting the facial nerve at risk in exchange for sometimes a 2-centimeter incision in a relaxed skin tension line. The current realities are what you see up here on the screen. Just as Bevan said, healthcare financial resources are contracting in the United States. There are cost-constrained initiatives underway in just about every medical center in the United States. Now, I did not do a thorough search for that. That's my impression. If there's anybody in the room here who practices in the United States whose medical center is not undertaking cost-constrained initiatives, I would appreciate if you'd raise your hand, because I would like to apply for privileges to replace. So the reality is smacking us in the face, that there are going to be less bucks in the system. We're expected to produce higher quality care, and indeed, this is in the light of an arena, an environment that we're trying to develop novel surgical procedures. And in fact, 30% of healthcare costs in this country are related to unnecessary services, diagnostic procedures, laboratory tests, imaging studies, whatever. So the American Board of Internal Medicine a few years ago began the Choosing Wisely program, the goal of which is to identify and reduce misused or overused medical services in an effort to decrease inappropriate care. The members of this program are some of the most prestigious medical societies in the United States: American College of Cardiology, American College of Radiology, American Society of Clinical Oncology, American College of Physicians, American Academy of Primary Care Physicians. And our academy for otolaryngologists, the American Academy of Otolaryngology Head and Neck Surgery, was one of the first, if not the first, surgical specialty to join this effort. And indeed, our academy identified 5 things that physicians and patients should question if they're ordered. And in fact, in conversation with leadership of the Academy recently, they tell me that now the Academy is embarking on identifying 5 more procedures that, in the Academy's view, are either misused or overused procedures. So this effort in the United States now is involving societies that represent in excess of 400,000 physicians who are embracing this notion of recognizing that we can't sustain what we're currently doing. We have to be more responsible. I think it boils down to this, in that David and I can have fun jawing at one another, but I think there's a little doubt that and David, you refer to this, it's imperative to universally and to agree and use metrics to compare and contrast. How do we define value? What is the improved efficacy? And quite frankly, some of these are loaded. So the big challenge is, how do you define best? And so I just made a list of things that I would think should be variables that need to be considered when you've developed a new surgical procedure. And so whatever these are, if they translate into more costs, but clearly I think we also have to recognize, indeed, that hopefully some of these variables would be more heavily weighted. In the case of malignancies, certainly mortality has to be a higher objective than the length of operative time, for example. But we're being naive if we think that we can continue down this road without constant consideration of total costs. I've become the nag at our departmental grand rounds because whenever a resident is presenting something, invariably the jerk Schuler Schuler from the back of the room is asking about, tell me about the cost efficacy of test ABC for the presumed improved diagnosis of whatever. And then clearly there's this whole nebulous thing of what is the magnitude of societal impact. But just as David said, I couldn't agree more. That's the one thing he said that I agree with, that special considerations, we always need to recognize that. So professionals who are dependent on aesthetics for success, I think this is something that we have to consider as it relates to, for example, transaxillary thyroidectomy. So whether it's performing artists, models, or facial plastic surgeons. So this is a Victoria's Secret supermodel. Victoria's Secret is a women's undergarment company that's headquartered in Columbus. And 15 years ago, they began the Victoria's Secret fashion show. So this is a supermodel that qualified to be in that fashion show. This is a group of supermodels that recently visited Columbus. Not all of the people in this photo are supermodels. But the point being is that, and in talking with the director of marketing for Victoria's Secret, incidentally, that fashion show is viewed by some 17 million people. It's viewed in 191 countries worldwide. This single fashion show is viewed by more people than all the rest of the fashion shows in the world combined. And so for these people who are competing to be at that level, there are currently about 5,000 models in the United States. Over the 15-year history of that fashion show, there have been about 150 models of those 5,000. So if you take those 150 models and you take a certain percentage that are going to develop a thyroid mass, I think it'd be easy for both of those patients to go to see David Terrace and get their surgery. And then the other thing, too, is we heard our keynote address this morning that spoke to the realities of costs. And so this is a real dilemma, isn't it? Because in the world of oncology now, some of the targeted therapies are unbelievably expensive. And so, but some of them are producing results, not yet in head and neck malignancies, but in other malignancies that can't be mimicked with any other of the cytologic agents, cytotoxic agents. And so if indeed there's an overwhelming benefit to therapy for a malignancy, but it's prohibitively expensive, is that something that we need to consider? Yes. So I think there's no question that we need metrics, but we need to weight those metrics and to individualize them. So in conclusions, yes, please do not imply that Dave Schuler is not at all about innovation and surgical innovation. That's what I've based most of my academic career on. So it is to be encouraged, but I do think that it is time now that we really need to develop an evaluation system. Should it be mandatory? Well, that's something for discussion. I'd like to have your opinion about that. If you go through that whole litany of potential variables that could be improved with a novel surgical technique, as is the case with Dr. Terrace's transaxillary gasless robotic whatever, and if the only thing is a cosmetic benefit, then I think you have done your deed. You have defined it as a cosmetic procedure. And so then that should become the responsibility of the patient. If there's no functional benefit and there are more costs to doing the surgery, that cost differential, I believe, should be borne by the patient and not society. And so I think it's important as we move down the road to recognize that we will need to be transparent with third-party payers, whether they're public or private. The magnitude of the healthcare problem in the United States is not going to be solved by the Choosing Wisely program of physicians. It's going to be solved only if there is genuine and sincere cooperation among the healthcare systems, the physicians, all the healthcare providers working together as partners in order for that to be effective. effective. It has to be transparent. And then in the interim, while all of this is being done, I think it's time for us to put some pressure on our journal editors of peer-reviewed journals to start expectations of those kinds of discussions whenever there is a paper submitted that is describing a novel surgical procedure. Should there be some sort of a requirement for indeed demonstrating the pros and cons of this rather than just describing how long the incision should be, et cetera. So in summary, I appreciate this opportunity, and hopefully I've convinced you that once again, David Terrace is wrong and Dave Schuler's right. Thank you very much.